Good afternoon again, and welcome to United TV. This is Kemal Erkan. It's our Bariatric Friday session with Dr. Isaias Irgau. He's here with us. Dr. Irgau, how are you doing?
I am doing great, Kemal. I am thrilled to be starting yet another year with more contents for our Bariatric Friday.
Absolutely. And we are starting with the new cycle to the new year. So it's kind of timely from that point. So we are, as many of you already know, usually there are 14 to 15 different topics. Today, there should be at least 12 different playlists in the channel. So you can actually look at specific topics. And this is more about our discussion that we have on a regular basis. And our goal is to kind of maybe retouch some of the issues that we did, give a little bit more technical background on the issues. And there are every once in a while when we have these sessions, some other things come up, and then we still cover those. So although it's a repeat as a topic, it's not a repeat as a session. We are here live, and Dr. Irgau just came from his office to be part of this. So thank you for everyone listening to us. And I know a lot of patients are, by now, they're following things that we do. So today we are going to discuss the bariatric surgery time. Yeah. So this is usually how we set the tone with our patients in the beginning. So what we are going to do and what needs to happen with them and how they're going to actually take charge of their future. So this is one of the important topics that we discuss at the time of the first consult. It doesn't mean that we don't discuss this later on, but this is the foundation of that decision. Okay, you are here, and now we kind of need to decide what type of surgery is the best one for you. So that's why we have the expert here. And Dr. Irgau, what would you like to tell us about the different surgery types? And then I'll have some questions as we go through.
Absolutely. No, sure. Thank you. Thank you. It's always great to be here. And then, although, as you said, the topics are very similar in many ways, we really present them in a conversational manner, emphasizing one aspect of the topic specifically in one session. So watching them is not necessarily watching a rerun of the same topic. Essentially, there are different ideas that may be highlighted on different sessions. As you say, today we're going to talk about types of bariatric surgery. And clearly, it's probably better to first talk about what bariatric surgery is, right? Bariatric surgery really is a surgical intervention which is aimed at making some change in the digestive tract so that we are able to influence hunger level, fullness level, and to some extent, the metabolism that is involved in energy processing in our body. And it's important to emphasize this because people have different ideas about bariatric surgery. Very often, it's not uncommon for me, for instance, to tell people I do bariatric surgery, and the first thing that comes to their mind is I take patients to the operating room and I remove all the fat that is visible in them, right? Or they think about something like liposuction. It's not uncommon for me to ask patients whether they've had any type of weight loss procedure, and they say, yes, I've had liposuction. Well, liposuction is a procedure where fat is essentially removed by the body, but it's not a bariatric procedure. It's more of a cosmetic procedure because really it has very little impact on the metabolism of the person. On the other hand, bariatric surgery is way more impactful in terms of what it does to our physiology. And it's useful to look at the bariatric procedures in terms of the ones where there is a change in the size of the stomach only, or procedures where there is also rerouting of the intestine. And that's a critical difference. Really, there are two main types of bariatric surgeries that are commonly undertaken in the United States or even in the world right now, right? And that is the gastric sleeve or the gastric bypass. Also, there is another version of the gastric bypass known as the duodenal switch as well, which is done less commonly. Other procedures that people may have heard of, the gastric band, the gastric balloon, are also undertaken, but to much lesser extent.
Mhm.
So let's talk about the most commonly undertaken procedure, which is the gastric sleeve or sleeve gastrectomy, or vertical gastric sleeve, as many people know it. Well, with this procedure, what we do essentially is we focus on the stomach itself. And the normal stomach has the shape of a watermelon. Not only it has the shape of watermelon, but it acts like a balloon, which means that when we eat, if there is more food coming, the balloon actually stretches and distends. So we are able actually to out-eat, to overeat whatever plate is presented to us, because our stomach is such such a shape that it can really accommodate a lot of food. Well, when we do the gastric sleeve, we really attack that ability of the stomach by making the stomach a lot smaller, not only just smaller, but by removing the portion of the stomach that stretches the most. So when we're done with the procedure, a stomach that started like a watermelon shape
Mhm.
now will look more like a banana. That is the essence of the gastric sleeve.
Now, at the time of the consult, in order to decide which one is the most suitable procedure, how do we actually make that decision? Patient may come to us with some made up decisions, but that may not be the best for them. But what's that process? How do you decide which surgery is the right one? And then I have some follow-up.
Of course, that's a very important question, obviously, because that decision, although it is a shared decision between the surgeon and also the patient, the surgeon will play a very important role, obviously, in guiding the patient, because the surgeon has the experience, the knowledge, and the know-how as well. I can tell you that for the vast majority of patients, any of those procedures will be fine in principle. In fact, when patients tell me what is the worst procedure I can have, I tell them the worst option would be to do nothing and let obesity run wild, obviously. So any of those interventions are fine. But clearly, some interventions are much better applicable to an individual than others. In general, it is no surprise that the vast majority of patients nowadays in the United States or even in the world choose to have the gastric sleeve or the sleeve gastrectomy. And the sleeve gastrectomy is appealing and applicable to the vast majority of patients because of its intuitive simplicity, right? The stomach is big, the stomach is distensible. Let's make it smaller so we can eat less food, we have less hunger, but also there are other metabolic benefits of the procedure. And it is a procedure that has a proven track record, not only in its results, but also in its safety. We talk about how the gastric sleeve, Kemal, now is as safe as very commonly undertaken surgical procedures like the gallbladder surgery or hysterectomy or even appendectomy to some extent. So the vast majority of patients who are looking for a robust weight loss, we're talking about patients wanting to lose 60 pounds, 80 pounds, 100 pounds, 150 pounds, the gastric sleeve will do with that safety track, but also with the fact that the gastric sleeve does not require rerouting of the intestine. Rerouting of the intestine, which is a process that is done when we do the gastric bypass, introduces issues and problems for the future that the gastric sleeve doesn't have. Having said that, there are some patients on whom the gastric sleeve may not be appropriate, right? For instance, patients who have had a very long history of acid reflux to the extent that that has caused damage to their food pipe, something that we call Barrett's esophagus, for instance. In that case, we say maybe a procedure that removes acid exposure from the food pipe, like the gastric bypass, is better applicable for the patient. So we discuss about the advantages and disadvantages of a procedure like gastric bypass as well. Both procedures, as we have said in the past, are procedures that we perform in our practice and we offer, and they are very often done in our bariatric center, which is the American Surgery Center, where the vast majority of the procedures are undertaken laparoscopically in an outpatient setting.
Now, the most common procedure that we do is gastric sleeve. in almost, I would say, 75 to 78% of
Yes.
cases.
Yes.
And another 22% is bypass. So gastric bypass is more, I guess, invasive in a way. But in some cases, it's the only choice that patient really should go. And in the case of managing diabetes, as you mentioned, the reflux, and other than just the structural changes, there's a important part that patient needs to understand what both can do. So in one of them, literally, we don't actually have any stomach functions, so that there will be a very little space there. But at that point, that's what they need. But if it's a 25-year-old patient or 27-year-old patient comes to you with no diabetes or reflux, that wouldn't be the go-to procedure. Is that correct?
Absolutely, absolutely. There is a misconception sometimes come out thinking that there is a difference in weight loss between the gastric sleeve and the gastric bypass.
Mhm.
By and large, those differences are not major. They are not very, very significant, right? So I think it is important for patients to understand that. Another misconception that I come across very often is patients saying, well, if I have the bypass, I will never regain weight. If I have the sleeve, I could regain weight. Well, that is actually not necessarily correct. In fact, patients can regain weight with any bariatric procedure. There was a bariatric surgeon that was teaching us when we first started over 20 years ago, who used to say, you can out-eat any bariatric procedure, which means that if you don't change your behavior, it doesn't necessarily mean that these procedures will do a magic thing for you, right? All patients have to understand that the biology that drives obesity is just around the corner, even when the surgery is performed. So they have to be careful. They have to be mindful. So we're not saying diet and exercise have failed, let's replace them with surgery. We're saying diet and exercise are not powerful enough by themselves. We're going to add a powerful tool to them, which is surgery. So we want you to exercise. We want you to focus on your diet still. And the surgery will be an extremely powerful tool that will allow you to lose the weight.
Well, obviously, the other important thing is if someone is able to make the necessary changes, necessary adjustments, so then they have the surgery, then that's it. So then they don't have to be on, not only they don't have to be on any medication, but if they're on medication for hypertension, diabetes, and other comorbidity-related, obesity comorbidity-related diseases, then they can be actually off medication, including sleep apnea and other conditions.
Absolutely. On that point, actually, I would like to emphasize one fact. Yes, there are, in terms of weight loss, there may not be major differences, but there are other important differences between the gastric sleeve and the gastric bypass, right? For instance, it's, as you mentioned yourself, the gastric bypass is much more powerful in really taking care of heartburn or acid reflux when it's compared with the sleeve. And also the gastric bypass has much more impact earlier on after the surgery on the resolution or improvement of type 2 diabetes. There is no question about that.
Can you elaborate the reflux a little bit? So like when you say reflux, first thing that, like, I'm not speaking from my position standpoint, but if I was the average Joe, the reflux is like if I'm burping. Is that what it is? Or
it's
like,
not. It's not. It's not just burping. Reflux essentially
these questions do come to me. That's why I'm asking.
That's right. Reflux essentially is the result of acid refluxing back into the food pipe. So if we look at the actual inside of our digestive tract, we look at the food pipe first, which is a tube that connects our mouth to the stomach. And then there is the stomach. Now, if you look at the contents of these two structures, you will see that the stomach can withstand very, very high levels of acidity. In fact, acid is produced by our stomach to help in digestion, whereas the food pipe does not have any acid, and its lining is not made to really withstand acid. So if acid comes back from the stomach into the food pipe, it actually damages the food pipe. And we feel that. We feel that acid coming back in our food pipe because we don't have a food pipe that is really made up to withstand acid. There are mechanisms that protect the food pipe from the acid coming from the stomach, but those mechanisms, sometimes they can fail. And that's what we have acid reflux, essentially.
So, but what's the cause of that, though? Like, why is the acid coming out and it's not staying in the stomach?
So, essentially, there is a valve-type mechanism that protects the contents of the stomach from coming back up into the food pipe, right? Those mechanisms are not just like a single valve, but there are the anatomic position of the stomach itself, the opening within the diaphragm, the muscle that divides our chest from the abdomen, has a very important sling-like structure that really constricts the food pipe and prevents things from going back up. But those things can fail for a number of reasons. Interestingly, one of those reasons is actually gaining weight and having increased the intra-abdominal pressure, gaining weight and leading to laxity of those valve type of mechanism. Pregnancy in women can do that. In fact, many women who don't have any reflux normally will experience reflux during pregnancy. So that can happen as well. But that can also be exacerbated by diet. It can be exacerbated by excessive alcohol intake and also smoking. All things that should also be addressed when somebody is having reflux problems. Now, it is important to understand that there are different degrees of reflux symptoms. There are some people, for instance, who will tell you, I have reflux if I eat something, acid type of stuff. Yeah, absolutely. That picture is actually very, very good in showing what we're talking about.
Right.
So there are some people who say, for instance, they have reflux every night and they have to take medication. So we have to really understand these degrees before saying, yes, surgery should be undertaken that will address the reflux issue as well. One thing that is also important for people to understand is that if they have mild or reflux that has not been there for a long period of time, having the sleeve gastrectomy and losing weight may by itself address the reflux issue. So just having some symptoms of reflux doesn't necessarily equate from, to going to gastric bypass.
And reflux with the heartburn, right?
Yes, heartburn and reflux. These are interchangeable terms.
But, what I was about to say is that this is also kind of like not maybe helping us to diagnose other issues.
Absolutely.
So like the heartburn it can feel like it's a heart issue as well, right? Like, and especially with female patients, this is a problem. So
yes,
that kind of like that's one of those things that people really need to understand, that this is not. Can you live with that situation on a daily basis? Probably not.
Absolutely not. I think if reflux is something that is happening on a daily basis, people need to have it treated, not only to relieve their symptoms, but also to protect the food pipe from that continuous bathing of acid that could damage it and lead to scarring or even more serious developments in the food pipe. So these are issues, actually, Kemal, you and I are talking about it, giving general guidance and education, but individuals who may be experiencing things need to talk to their doctor or to their provider to make sure this is addressed. And to the point that you brought up is important. Sometimes the reflux symptoms could be an indication of heart disease, actually, in certain situations. So they cannot be downplayed in such a manner. In fact, certain tests may need to be done to diagnose this, and medications are also very important.
And from our point, though, like why it's important is because now when the patients sometimes don't really understand why they should be doing bypass over sleeve, is because the whole function of the stomach and this acid being in the stomach and eliminating it, which becomes a permanent solution with this sleeve. Now, again, if the patient is 58 years old with diabetes and heartburn, and they come to us and they want to have lap band, so what's our course of action to kind of change and have the patient help the patient to make a better decision and then go with the better procedure? How do you handle those?
Absolutely. So essentially, the lap band, as we've mentioned it in
I
our
kind of
session, is
specifically said lap band because that's kind of like something that we don't do as much.
It's a procedure that is still available. It doesn't require any cutting of the stomach or of the intestine, and therefore that may be the appeal that it has on people. It's really a belt that is placed in the upper portion of the stomach, right below the food pipe, and creates a tightening that interferes with the person's ability to overeat. That's how the band works. It's connected by tubing to a little device that is left underneath the skin, where we can insert a needle in the office and adjust the tightness of the band. That's why it's called adjustable gastric band. So it is a procedure of fairly low risk when we think about its placement. And because there's no cutting of the stomach, there's no cutting of the intestine, by itself, it's a reversible procedure because we can remove the device and the anatomy will be left the way it was, although scarring obviously will still occur. So that's the appeal of the band. But it's not a powerful procedure in terms of the amount of weight people lose, but also very often the quality of life with the lap band may not be appealing because very often patients will be struggling between having the band too tight or too loose, back and forth like that, with episodes of regurgitation or even throwing up, which may not be predictable. For a number of reasons, for these reasons, the band has not stayed as popular as it used to be like 15 years ago when we used to do many bands. In fact, we find ourselves removing many bands nowadays, but it is still an option. It is still a device for somebody who is absolutely psychologically against having any portion of their stomach removed or cut.
It's almost like when you get a car 30 years ago, the windows were not all automatic, right? So we had to have the manual one. And now there's a better way to do it. So do you still want to have the manual way of doing it versus when you can make it effectively? So it's not like we are saying that, hey, this is better than that. This is more advanced than the other one. So, but I think there's this misperception which we always have to deal with, where because of the level of whether or not that's invasive, how much actually it has to be done in the stomach and this and that, people do understand these things a little bit differently and in a wrong way in many cases. So when you are 57 years old, BMI 47, you have diabetes, and I give these specifics for a reason. So this, if you have diabetes and heartburn and 57 years old, BMI 47, bypass is the way to go.
Absolutely.
But if we take the same patient to 37 years old, no diabetes, no heartburn, gastric sleeve would be the first option that we would go, because that 20 years, that gives them a way of fixing the problem with gastric sleeve. And since they don't have the comorbidities with diabetes and others, so this is a way to kind of set them up, as 57 would be kind of way too late to have another procedure 3-4 years after the first one.
So I think those are reasonable points, but clearly one of the issues that we struggle with, Kemal, is this stigma against obesity. And patients also carry that stigma with them, carry this idea that it's their fault, and therefore they have failed because they have not been able to address the issue. And this is really a failure of seeing obesity as a disease, right? If somebody develops cancer of the colon and they go to their doctor, the doctor says, I need to remove that segment of the colon for me to cure your cancer, there will be no discussions. There will be no discussions because they understand that, right? Now, we're looking at obesity differently because of the societal pressure also to view it as something of our own doing, as opposed to something that is biologically driven and something that is a disease process that is driving many illnesses, right? If we saw it in that manner, then our perception would be different. So what happens is when people hear the word bariatric surgery for the first time, even though their BMI is very high, they reject that idea. They say, no, that's not for me. I'm not going to have surgery. And then obviously they struggle. And over a period of time, the idea matures in their head that maybe they should look into it.
Mm-hmm.
And when they do, they want to go for something that is least invasive, right? So they hear about the lap band, they hear about the balloon, which they have a place, but not for somebody who has a body mass index of 55. That just is not realistic in terms of the impact those procedures have. We need much more powerful tools like the sleeve or the bypass for us to have an impact on somebody who comes with that body mass index and with those complications of obesity.
Well, I think some of the issues that we discuss, because this society that we live in, we as not just healthcare providers, not just business people, not just who we are, but we are part of the society as a person, and we are part of some of these discussions. So I just want to actually, as you were just giving the example of the cancer, and I won't mention names, so they don't have to worry about their names being outed here. So, but couple of my managers, I was just talking to them on Tuesday, and the issue was totally on the level of care that insurance companies are giving to the people, and at what point you say enough is enough. And I was just giving them a couple of examples, and they were not happy with my examples. So I said, like, for example, someone who's 90 years old, do they still need to go through the chemotherapy? And even then, I just checked their, reactions, and then they're like, "Yes, of course. Like that's what that person should be doing." Well, what about dialysis? Yes, of course. Well, here I have a patient, BMI 55. I have a patient with BMI 55, and I let them leave my office without a plan of taking care of morbid obesity. So this is why we are actually discussing this. So if we think that doctor would be almost unethical by not treating someone who's 90 years old, are we being ethical when we let those patients go from our office with those high BMIs? And also, patients always, they need to ask themselves, why is it okay that you want your grandma to be 94 years old, who's pretty much just waiting to die, but then you don't, pull the life support and then torture her in that condition for 30 days because that's the right thing to do. But then you yourself is like BMI 55, and then you're not taking care of yourself, and then you're not letting the doctor to talk to you about it. So we have some patient satisfaction issues that we see. I actually read them. I'm like, reading it, I'm like, are you serious? Patient's upset because we brought the BMI problem. Well, this is a disease, and we are medical offices, medical professions, and we have to take care of this. So this needs to be kind of no issue anymore. So Absolutely. If we still worry about, hey, like I'm going to hurt his feelings or her feelings, well, when they're like, I told one of the patients from our case conference in the bariatric program, and patient's A1C was 12, and I told the patient, hey, you're going to die. You don't have to have the surgery, but you need to take care of the A1C. So, Absolutely. Well, I didn't tell her you are going to die. Your BMI is 60. I'm just, criticizing myself too. But I felt so comfortable saying that, hey, you're going to have a heart attack soon. What's going on with this, right? But then I should have said, this is going to kill you. High BMI is going to kill you. Absolutely. I still couldn't say that. Now, as I'm just telling you this, I'm just questioning myself, why did I not? Because that should be the first line of communication, and then I can put the other ones, but I couldn't. That's the stigma that still controls how we feel and what we say.
It is. And because of that, patients sometimes can be very defensive about it as well, and our approach doesn't have to be as direct sometimes. You know what I'm saying? So, for instance, one
This
of
was
the
a
ways.
non-compliant
No,
patient.
no, I know, I know. So, for instance, one of the ways in which I approach this issue, and I have patients who come in to see me for not for obesity, but for other reasons, and I know the obesity issue is central to their health, I would just say to them, hey, are you comfortable at the weight you are in right now? That opens up the conversation for them to really let me dive into it. But sometimes patients surprise me as well by really being ahead of this. Like I had a patient the other day who came in for a hernia repair. And I asked them, do you have any other medical problems? And he said, I have obesity as a medical problem. And I was really felt great about it because the patient looked at obesity not necessarily as an appearance issue, but a health problem.
Which is important.
He identified that as a medical problem. And that was gratifying because that obesity issue also has an impact on what we were going to do about the hernia. They are very much interrelated. In other words, if you have somebody who comes to see you with a body mass index of 52 and they have an umbilical hernia, there's no point in fixing that hernia, because it will come back, right? You have to address the issue of obesity very, very, very much so that the hernia can be repaired in a permanent fashion.
So, Dr. I want to also spend a little bit more time on the revision, which it brings the different surgery types. So, we see revision from gastric band to gastric sleeve, from gastric band to gastric bypass, or from sleeve to bypass. And some patients who have sleeve or bypass may have issues with reflux, or the patient with sleeve. And they may come back. And can we talk about those surgery types? And we do those at American Surgery Center.
Absolutely.
And the reason we are actually also pointing this out is because there are, as the treatment is still relatively new, this is like 20 years, actively 22 years we are doing it. So things are changing, and then there are good benefits, especially for those patients who have band and then they didn't have the successful outcome. They can consider. So if we can just talk about the revision a little bit, that would be
absolutely
great.
So revision essentially means doing another bariatric procedure on somebody who already has had bariatric surgery. And we should not have to be defensive about it, right? Because it's a disease and one treatment may not be sufficient, right? Somebody, who comes with a cancer of the colon, you remove that, and then a few months or years later, they have another spot, right? You go back and check it out again, right? Because the disease can do that. So with obesity, although everything is done so that they are successful the first time round, sometimes they may not be for a number of reasons. So we have to be prepared as to give options. And the options sometimes include medical weight management, but sometimes another type of surgery. So it is not uncommon for patients who had particularly the gastric band to have the band removed and then go on to have the gastric sleeve or the gastric bypass. Or patients who've had the gastric sleeve, as you mentioned correctly, if they develop heartburn, which becomes very difficult to manage, we revise their procedure to gastric bypass, right? Or patients who've had the gastric sleeve and their weight loss stalled, for instance. They've lost 80 pounds, but they have another 100 pounds to lose or another 80 pounds to lose to get to a healthy weight. It is not unreasonable for us to offer them a intestinal rerouting procedure like the gastric bypass or the duodenal switch for them to continue their weight loss journey. So in other words, yes, we do procedures after the initial bariatric surgery, and those procedures are offered at the American Surgery Center or also at the hospitals, depending on the situation. And not everybody needs that, but there are some patients who need that. Obviously, we do detailed evaluations to make sure that that is appropriate, and then we discuss with the patients in depth as to which procedure might be best for them. In this respect, I do want to mention a very important difference between the gastric sleeve and the gastric bypass. With the gastric sleeve, as I mentioned before, we remove a portion of the stomach, but we don't do rerouting of the intestine. With the gastric bypass, on the other hand, we've cut the stomach and we've rerouted the intestine. If we need to do something different, there is very little room after gastric bypass. Whereas the gastric sleeve can be switched into gastric bypass without any problem. So when I talk to patients, I often tell them the gastric sleeve is like a midway procedure that gives you still a door open for you to do other procedures if necessary. Whereas the gastric bypass is a final stop procedure because there is very little maneuverability afterwards. And it is another important thing that patients need to know before making a decision as to whether to go with the gastric sleeve or the gastric bypass.
All right, that makes it even more clear for us to better understand. So there are so many different surgery types, and we discussed some of them, and we are going to discuss more because we discussed different topics of morbid obesity in this cycle. So I don't want to spend too much time on the risk and expectation. Next week, we are going to do expectation. The following week, we are going to do the risk. So we'll be going into the details. So, but understanding that there is a tool that actually is the most powerful, and only very limited number of people who are taking advantage of this, and also the safety of these procedures and us being able to do this successfully in the outpatient settings. And most 99.9% of our patients are going home same day. This is kind of speaking for how good what we are doing, and also it also kind of speaks to the level of severity of the problem. It is not so you can go home same day, and then you just need to think as like if you have a gallbladder procedure. So, but the only advantage is you have more preparation for this than any of the other general surgery, emergency general surgeries. So we are here for those who wants to take advantage of these tools and make your appointments. Go to CHRIAS website and you'll see the prompt for making an appointment. And we'll be seeing you soon. Well, we'll be back next week. And until then, stay safe and thank you for watching us.
Thank you. Thank you.
Bye-bye.